Renal denervation technique. An important exam related question. Renal denervation technique, sometimes called as RDT. RDT. Sometimes called as renal sympathetic denervation. Renal sympathetic denervation, RSD. Renal denervation technique is the latest terminology which is being used. So what are the heading we are going to see? What is it? What are the indication, procedure, how it is being done, what are the contraindication, and what complication can occur in this procedure? Renal denervation technique. Basically what we are going to do is sympathetic nerve supply to the kidney being we deliberately destroying the sympathetic supply to the kidney. Renal sympathetic denervation. Any organ will have sympathetic and parasympathetic nerve supply. Why we are going to stop the sympathetic, or we are trying to destroy the sympathetic supply to the kidney? Once the sympathetic supply to the kidney is overactive, it causes the vasoconstriction. Because of the vasoconstriction, sometimes the release of renin will be more. More vasoconstriction, the kidney will sense it has a higher resistance. Subsequently, what will happen? The feedback mechanism will get activated. Basically, renin will be secreted more. Renin, as it gets secreted more, the RAS system will get activated. RAS, renin, angiotensin, aldosterone system will get activated. Overall, there is a vasoconstrictive state leading to the high blood pressure. That is why we are targeting to denervate the sympathetic supply. Why we have to? Because BP is on the higher side, blood pressure is on the higher side. Simply, what is it? We are trying to cut down the sympathetic supply. Why? Because it increases the blood pressure. Now the natural question comes. There are antihypertensive drugs which are available. Why can't we use that? There comes the indication. What are all the indications of this? So let us leave this image for a few seconds. Indication: an uncontrolled BP. BP on the higher side despite taking 3 antihypertensive medication. Despite having our patient already taking 3 antihypertensive medication at adequate dose, and the patient compliance is clinically checked. The patient is at risk of complication of high BP because it is not under control. The patient is not tolerating the drugs. Why? It can be of many reasons. The drug having its own side effect, any side effect for that matter. The patient not tolerating, the patient could not take BP on the higher side. To put it in simple term, a resistant hypertension. There are many criteria which says diuretic should be there, AC inhibitor should be there, ARB should be there. First point is BP is not under control, more than 140/80 despite use of 3 antihypertensive medication. Maximal dose, few criteria says diuretic should be one among them, AC inhibitor should be one among them. These are all the things they will say. But consider 3 drugs. In turn, it is resistant hypertension. Patient not tolerating the drugs for any reason. Patient not willing to take, or whatever the reason may be, for the long-term benefit. Or patient who want to step down the drugs, tell some latest treatment, I don't want medication. Yes, this can be considered, but it is not a replacement for patient coming with BP 160, straight away you will go for denervation therapy. No. First you start with antihypertensive, consider, then decide. In this indication only we will decide which are the patient to select. The patient glomerular filtration rate or kidney function should be at least above 40, below which contrast itself will cause renal damage. eGFR should be high, more than 40. The patient should not have any secondary cause of hypertension. For example, if the patient is having adrenal, some lesion, for example a benign tumor, It itself causes high BP. During that time, you can't come and put this. The BP is high and not under control. That is why adequate evaluation is required. First, we have to evaluate why the patient is having hypertension. There should not be any secondary cause. Any secondary cause. For example, coagulation of aorta. For example, vasculitis. If it is there, this procedure is of no use. Rather, it will do the harm. So in the indication, we have seen resistant hypertension, eGFR should be high to consider this procedure. More or less, it comes under the contraindication if GFR is less. Renal artery stenosis should not be there. Secondary causes should not be there. I hope a resident or a nephrologist who is seeing this video good enough to pick the indication and contraindication from the discussion only, rather than saying it separate one by one. In the contraindication, any patient who are at risk of radiation should also not be considered for this procedure. Okay, what is the base behind this? The base behind this, the technique we are going to use is radio frequency ablation or ultrasonic waves. Automatically doubt comes, how we are going to use, how we are going to destroy only the nerves. The vessel and nerves are almost close by, almost one on another. How we are going to destroy only one? Previously, it was the ganglion destruction which was used. You have to cut open procedure. But in those, the complication was high rather than the benefit. But rather, afterwards, what they have found, there are so many angiographic procedure we use in heart, we use in brain. Why not in the kidney? There only they have found this intraluminally. Through the blood vessel we will go, the vein, artery, vein and the nerves are almost nearby. Through the artery we will try to destroy the nerve. The radio frequency ablation or ultrasonic waves, the dose at which we are using might not harm the arterial vessel but will destroy the sympathetic nerves. Once the sympathetic nerve supply decreases, the vasotonicity decreases, thereby the BP comes under control. So what is the technique? The technique is similar to any angiographic procedure. Under sedation or a short GA, general anesthesia. Most of the time under sedation it is being done through the femoral artery, the catheter being passed. We have to make sure the patient is not having any kind of renal artery stenosis. So once we pass the catheter inside, here radiofrequency ablation or ultrasonic waves can be used. Similarly, the catheter will come through the femoral. Here this will be emitted starting from distal towards medial. Not going into the details how it is being done. This is the model how it is being done. Just we will go from the distal to proximal. The rotation wise we will start removing or start destroying the sympathetic nerve fiber. So it is an AI generated image, and this is how being done, similar to any angiographic procedure. What are the contraindications? Renal artery stenosis, secondary causes, eGFR less, of course patient not willing. Here with respect to the practical problem, since many a times hypertension patient might not have symptom chronically, they will be reluctant for this kind of procedure. As the evidence is growing up, more patients are now willing towards this particular procedure. So as soon as the procedure is done, similar to any angiographic procedure, patient have to be kept in bed rest for at least 48 hours. Hematuria can happen. Patient BP might fluctuate. And one more point to mention here is BP might not drop immediately. It might take few buffer period because sympathetic nerve supply went down. The arterial tonicity changes. Renin comes down, then the BP comes down. It might take approximately 2 to 3 weeks or even months, as per the patient criteria. So this is the how a procedure being done. Contraindication we have discussed. What are the complications which can happen? Similar to any procedure: arterial injury, renal artery rupture, renal artery stenosis, thrombosis, needle site pain, needle site aneurysm, contrast being given AKI, acute kidney injury can happen. Patient can go into shock. These are all some of the documented complications. Coming to the last part, conclusion. What is it? Renal denervation technique, renal sympathetic denervation is a new modality of treatment in the treatment of hypertension. For resistant hypertensive patient who does not tolerate drugs or who doesn't want to take medication or BP is not controlled with the medication, despite adequate dose, compliance being checked and BP being checked adequately. Ambulatory BP monitoring on an ideal basis. Indication we have seen. Technique, radiofrequency ablation or ultrasonic waves can be used through the vessel we are going, renal artery preferred vessel. Contraindication, rule out secondary cause. Make sure patient renal artery stenosis is not there, eGFR is good. And the technique we have seen how it is being done. From distal to proximal, we will use the rotational type of movement. And it is a OP based procedure, but the patient might have to stay in the hospital. But the technique is being, now the new techniques are coming so that patient can be discharged at the earliest over a period of 2 to 3 days. In the complication, hematuria is a thing which is expected after the procedure, but any angiographic procedure which carries the complication, similarly this also carries the complication of AKI, artery rupture, arterial stenosis and all. Will it reduce the BP? Yes, it can reduce up to 8 to 10 millimeter of mercury over a period of time. Yes, it have shown beneficial, but it not mentioned as a treatment guideline. This is the recommended treatment, like that it had to come. One trial for a medicine resident who have to remember a trial related to this technique can be a simplicity trial. That trial you can remember. This is a short intro or a short discussion regarding renal denervation technique, renal sympathetic denervation. Trial and all, probably in detail only a DM resident will get the question, not the MD resident. I hope this is enough for the MD resident to write your theory exam and also confidently answer your OA question. Bye bye. If any comment or any question, comment below. In the next video we'll see. Bye bye.